Okay, this is the thoracic sequence. First you test thoracic side lying rotation. So the patient lies on their side, hips and knees bent to 90 degrees. Put your hand behind the top leg, proximal tibia, and then tap their scapula and have them try to touch this to the table. Normal would be this melting to the table, right? So this is about 50% of the range. Now we're going to do the thoracic sequence. The first two things are piriformis inhibition. Piriformis muscle runs this way, so you're just going to pull your fingers and thumbs together. This is moderate pressure. If I stand lining myself up with the femur, then I know my hands are in the right direction. Okay, so you don't want to be here. You want to be lined up with that femur. About 7 to 10 seconds here. Then take your knuckles or the heel of your hand and in one direction release the fascia around the IT band and the vastus lateralis. Okay, so piriformis inhibition, and then release the IT band, and then recheck the range of motion. See, this is a lot better, so her restriction was primarily at the hip. And we're going to go up here to do thoracic nags. Here's the hand hold. Pretend like you're shooting a gun. Drop your thumb down 90 degrees, and it is the middle phalanx and the flat side of the thumb that are going to be applied to the transverse process. The spinous process is going to be in between. So starting around T2, I'm pushing in, I'm holding it in, and then I'm gliding up towards the eyeballs. This is what it looks like. Find a spinous process, split your fingers. You know your fingers are on the transverse process if there's about an inch of space in between. The biggest mistake students make is to be in too close. So I'm going to do thoracic sequence all the way down to about T8, which is the bottom of the thoracic kyphosis. Notice how my arm is in line with my wrist. This gets a lot harder if your wrist is bent this way, so keep your wrist straight. You can also see how I'm using my body to push and apply the distraction, the anterior push. So this is an anterior superior glide. All right, once you go down and up, then you can do the posterior rib mode. So you want to stand, I need to swing around here. So you're going to stand now lined up with her arm, the hand that's closest to the hip. If you put it on the rib cage, you'll be able to do this posterior rib mode. Now here's the spinous process. If you palpate, there's going to be a little divot, then the roundness of the paraspinals, and the next kind of bony bump you feel is the costal angle, and that's where you want to place the heel of your hand. The ribs angle down at a 45-degree angle, and so I'm trying to move the rib cage this way, right? So with the heel of my hand, doing a grade 4 rib springing. I have room for about 2 or 3 hand positions because you're getting 2 or 3 ribs under each one. Okay. And then from here we do the latissimus, we call it the lat squeeze, but it's really a fascial mobilizer. So you're not grabbing the muscle, you're grabbing the skin over the muscle right here in the posterior armpit area. And I am just alternating, grasping, using a lumbrical grip. It's much more comfortable to the patient if you use this grip versus this. Okay, and then the last 2 parts of the thoracic sequence. This usually clears it totally, so I usually test it again, roll that shoulder back. If it's still not clear, then you're going to add the last 2 parts of it, which are done in the front. So the next thing is pec minor inhibition. So the pec minor runs from coracoid process to ribs 3 through 5, so I'm going to inhibit here, pulling my thumb and fingers together. And then the last thing I do is an anterior rib mode. This time I'm using my hand closest to her head. If I'm standing lined up with her shoulder here, I can place the heel of my hand, the thenar eminence, edge of the thenar eminence, on the sternum, slide off of it a little bit, and then I'm just doing grade 4 oscillatory pull up towards the shoulder. And that's it. That's the thoracic sequence. Okay, so this is how to check for somatic dysfunction in the thoracic spine or vertebral rotations. So find the spinous process and then split your fingers about a 1/2 inch on each side, right here. And with your thumbs flat, you're just assessing if one thumb is deeper. See this one, the right side looks deeper. I want to remind you that your dominant eye should be centered over what you are looking at. Okay, if you find a segment that's deeper, we'll go back up here. Here it's deeper on the right. You can use the head to make a correction down to about T4. T3 is at the level of the spine of the scapula. So here's T3, T4 is the next level below it. T6 is at the level of the inferior angle. So those are just like quick landmarks you can use to figure out where you are in the thoracic spine. So here it's T3. Once I see it's deep on the right, go ahead and look down. It gets better in flexion. Look straight ahead, and now tuck your chin straight back. This is how we do extension, and it's worse in extension. So we have what's called an FRSL. The right side is stuck in flexion and rotated to the left. So I'm gonna treat it an extension, rotate, side bend right. And because it's a T3, I can use the head. So I have her help me. I have my fingers here on the spinous process to monitor the movement barrier. Tuck your chin back, and then tip right, and turn right, and I'm just moving each plane until I feel movement here at T3. Gently tip your head to the left. 1, 2, 3, 4, 5. Relax. Tuck your chin, tip a little more right, turn a little more right, and then tip left. 1, 2, 3, 4, 5. Relax. Tuck your chin again, tip right, turn right, and push left. 1, 2, 3, 4, 5. When she relaxes, I passively return to neutral, and then I come back and recheck. Okay. If it's down below T3 or 4, between T4 and about T10, you'll use the trunk to make a correction. So here we have a whole bunch of segments here that are rotated left, deep on the right. Slouch for me. It gets worse in flexion. Sit up tall. It's better in extension. So we're going to treat in flexion and side bend and rotate away from the prominent side, which is the left side in this case. It's deep on the right. So here's a demonstration of treating in the flexion position in sitting. So the patient has their arms lightly crossed on their chest, give you a place to hold on to. Then I'm going to treat her in flexion. So look down, and I have her slouch until I feel movement to that spot. And I side bend her towards me. Turn towards me and turn your body to the left. In this instance, we resist rotation, not side bending, because it's a little easier for you to handle. And then slouch a little more. See how fine these movements are? There's not a lot of movement happening in between each isometric contraction. Relax, and then one more time. Slouch, tip right, turn right, push left. 1, 2, 3, 4, 5. Relax, passively return to neutral. Okay, if we were going to treat an extension, very similar position. You always want to side bend and rotate them towards you. So if she needed to be treated rotating to the left, then I would have her change positions, right? But if we were going to do extension, I simply tilt her back into extension to that point, side bend and rotate. Okay, so this is how you manage muscle energy from T3 down to about T10. Below T10, you use the sideline positions that you learned for the lumbar spine. The stuck side's always up, and you treat in whatever direction gets worse, flexion or extension. That's muscle energy for the thoracic spine. Okay, this is the muscle energy technique to correct an elevated first rib. Okay, so arm elevated here. This is to relax the scalenes. I can move my leg out a little to get a little bit more arm abduction. Then I side bend her head towards to shorten the scalenes, right? And then I have her gently push her head to the right while I push down and in. My hand is here. And 1, 2, 3, 4, 5. Relax. So I'm pushing down towards the belly button. And again, push. 1, 2, 3, 4, 5. Relax. And one more time. 1, 2, 3, 4, 5. Relax. Here's how you assess if the first rib is elevated. First rib is right at the base of the neck. So you take your hands, the web space of your hands, and you just apply a posterior anterior push. And it should feel springy. Somebody who has an elevated first rib, it'll feel like you're hitting a little bit of a brick wall. And it might be a little tender and painful, okay? That's correction for an elevated first rib.